Okay, can everybody hear me?
Yep.
Good. Okay. Hey, thanks everybody for tuning in to our Foregut Pathology series. This is our fourth segment, um, and we're excited to hear from Jacob Mormon. Most of you know. He is going to be sharing with us today some information about GERD, which is a common thing we see in practice every day in clinic and endoscopy, and it'll be an interesting take on it, a surgeon's perspective on GERD. I'm excited to hear what he has to say. I'll come back in at the end and you know provide some questions, some Q&A, help facilitate if you guys have questions. I have a few myself, and without further ado. One other thing I wanted to plug for those of us in Jackson, GI Associates folks, Jacob and Pierre will be providing coverage, surgical coverage at St. Dominic's in the coming weeks. So we will have the ability to use them and allow them to help us take care of patients there, which will hopefully can break down some of the barriers we have in dealing with UMC in some areas. So also really exciting tidbit of news. So Jacob, take it away, man.
All right, thanks, Brooks. So like you said, this is our fourth in the series. I'm putting myself on the hook for at least one more, although I'm not going to commit to a date right now. We're just going to say spring, summer, as it gets warmer. And as he mentioned, or you saw the title, this is going to be a talk mostly about the anatomy of GERD and how it's an anatomical disease. And then subsequent, next time we'll get into the procedural interventions and what we can do about those anatomical defects. So if, like Brooks, you have a bunch of questions about surgery, we'll try to hang on to those for the next go around. For those of you looking for the CME credit, Dion is going to email those to you, but there's the code at the top. It'll be, again, at the end. And those are some of our social contacts if you want to reach out or follow us. So no disclosures on this talk. I will, however, issue a disclaimer in that I intentionally did not say the surgeon's perspective. This is a surgeon's perspective. Some of these will be universal, but a lot of these are just my thoughts on an issue that we see with some frequency. So take that for what it's worth. So the stated objectives, we're going to talk about the workup of GERD and get into really how the anatomy impacts that, and then discuss some of the mechanisms that lead to that degradation of anatomy that break down the barrier that allow for the reflux to happen. But aside from the objectives, if I could sort of state the thesis for the talk overall and sort of how I frame my thinking on this topic, it would be that anatomy is the problem, some transient leading to some permanent. The symptoms are the juice, both acid and non-acid, but the danger is in the acid. And we're going to sort of unpack that in reverse order and talk through those as we go to sort of show you a little bit, maybe open up a discussion or a different way of thinking, talking about how I approach these GERD issues. So there's no universally accepted definition, which is important to state right out of the gate. We don't necessarily all even agree on what GERD is. So if you go through the literature, you'll get a few different options. So commonly, presence of symptoms is a determination, but we know that a lot of these can be asymptomatic. Endoscopic or histologic changes is another way to determine it, but certainly those are not always present. And then presence of a 24-hour pH study is not a 100% sensitive test. So there's not a perfect definition. And then on top of that, reflux, so gastroesophageal reflux, not reflux disease, is normal. 24-hour pH studies show that the acid exposure of the lower esophagus is almost universal occurrence in humans. So generally, where does that leave us other than a little bit mixed up? So I want to take a practical approach to how I would think through a reflux, how I think probably most of us do. And that's one, to think about the pathology. So these are going to be the visible results of reflux, Barrett's, stricture, esophagitis. These are incidences where there's no question that you're dealing with reflux disease. If we know these, we have GERD. And then the other is going to be in the presence of symptoms. Once you've appropriately vetted those symptoms, which we'll talk about in a minute, you've probably also got GERD. So pathology and symptoms are going to be the easy way out of making that diagnosis for us. So, so this is a decent little schematic that sort of leans into that a bit, walking us from that normal LES to GERD, and then what happens as a byproduct of that. So I don't know if my pointer shows up or not, but I'm going to pretend like you can see it even if you can't. So esophagitis leading to erosion, leading to peptic stricture, all of these potentially having a pathway back to Barrett's esophagus, which is where we get into our pre-malignant state. Now, I'll contest a little bit some of these statistics on the slide, though I like the visual overall. I would say that based on a previous discussion we've had in this series, that the risk of transference from GERD to Barrett's esophagus is on the low end of that, probably more like 7 to 10%. And I gave a big section of the talk on how the risk of Barrett's leading to cancer is way overstated at this 40 times increase. It's probably more like 10 times when you think about all the people with Barrett's. Now, once you have high-grade dysplasia within Barrett's, then you're looking at a 30% chance of conversion up to cancer. But importantly, what's the role of PPIs in all these? Do they decrease the risk of cancer? This is obviously a bad disease. So the danger is the acid. So non-acidic reflux is less damaging to the esophageal mucosa than acid reflux. That came up again and again in the papers that I read, and it's sort of an agreement, an assumption amongst practitioners that once we get the acid under control, we have largely, if not completely, reduced the ongoing damage to the mucosa. So stated pretty eloquently, I took this from Peter Karillis, who we're gonna crib from a lot in this talk. Primary determinant of mucosal injury is excessive esophageal acid exposure, attributable to anatomic or physiologic defects at the EG junction. So anatomy leading to acid exposure, leading to damage. So here's a little study, interestingly, of 26 GERD patients and 10 healthy volunteers. Half of the GERD patients had erosive changes, half of them did not. So they were equal non-acid exposure. So the refluxate that was not acidic was equal in both parties, but those who had erosive disease, where we saw injury to the esophagus, they had greater acid reflux, especially when they were laying flat. So the acid is the injurious portion of the refluxate. So if we've got this pathology, can we treat it? What have we shown to be able to do with PPI treatment? So this is looking at healing rates of endoscopically obvious pathology. So healing esophagitis with PPI therapy. And we can take away a few things from this study. There's a couple graphs here that we'll table figures that we'll look at. So number one is that taking all of them in together, there's a pretty good rate of healing, close to 80% of the visible esophagitis. It improves a little bit when they double the dose, going up from 60% to almost 80%. This is also where we get the statistic that about 40% of people do not respond or have inadequate response to PPI therapy. So there's still a pretty decent chunk at once-a-day PPI therapy that don't even heal visible esophagitis. Now, when they break that apart into kind of, you can think of high-grade and low-grade esophagitis for those in the audience who aren't practicing gastroenterologists, you see that the lower-grade esophagitis really pulls the numbers up. It's healing really well. Whereas when you talk about grade C and D esophagitis, it's a little incomplete. Certainly the once-a-day dosing was fairly poor. Once they doubled the dose, you got up to 2/3 of them healed, but there's still a decent chunk of those that are left inadequately treated. And those are going to be the patients that we're going to talk more about who are either who are refractory GERD or inadequate treatment with medical therapy. Here's another study. This is from a Scandinavian journal where they had a even better response to daily dosing, upwards of 90% healing of esophagitis in those patients there. So certainly PPIs are going to take out the pathology, at least in regards to the reversible elements of the pathology, with pretty high efficacy. So I think we can say that we know what the PPIs do for us in this regard. I think the question remains how symptoms play into all of that. We certainly all know that patients don't just all go away when you start treating them with PPIs. A lot of them persist with varied complaints of different symptomatology that needs to be addressed. And that's because, like we said at the beginning, in my mind, it's the juice that causes the symptoms. So sometimes that's acidic and sometimes it's non-acidic. So broadly speaking, again, we're sort of leaning towards this idea of refractory GERD. So let's talk kind of about the size of the problem. About 40%, like we said earlier, of GERD patients fail to respond completely to the standard dose PPI. 2/3 of patients on chronic PPIs don't report good satisfaction. So that's very much in keeping with what we alluded to earlier, that you're going to have probably a good response to some of the visible pathology, but not necessarily a good response in terms of symptomatology. And then PPI refractory GERD is the most common presentation of GERD to most clinical gastroenterologists. So a lot of the folks in the audience here know about this problem. So here's some important caveats that I've had to think about more and more lately that I think we should all kind of put more forward in our thinking. So setting reasonable expectations is big. We know that I didn't put up any of the Mississippi or US stats, but we know there's a heavy prevalence of reflux disease in this country as obesity and other factors push it forward. So talking about what to expect is key. So complete resolution is rarely achieved. So that's important. No one's going to be perfect. Nobody, it doesn't mean that everyone needs to go on to having a surgical referral and having surgery for reflux if they have imperfect results. Now that maybe they should, but I think talking about it in advance, that we're not looking for this to be 100% effective and completely normal again is important. Reduction of symptoms to a tolerable level is key. That's what you're after, optimizing quality of life. So finding a sweet spot. And then you've got to ensure correct medication administration. Make sure they're taking it correctly. They need to be taken 30 to 60 minutes before a meal. PPIs only work when they bind to the proton pumps, and those aren't actively secreting acid during a fasted state. So a lot of people take these, first thing in the morning when they wake up with their coffee, and then hours later they're eating, or they're taking them as needed. Less than 10% of the pumps are active during fasting. 70% are stimulated by a meal. So getting in that window just before a meal is going to be the most effective. And about half of patients are doing that. So we kind of talked about that in a previous discussion, but I think it's always good to go back over that with patients before we escalate care. Another thing to consider is the interplay of esophageal hypersensitivity. So this is again sort of in the part of the discussion about making sure you've got the diagnosis correct and complete as you work through some of the refractory symptoms. And this was a concept that for me, I thought of as you go all the way up to the line, and then past that line is hypersensitivity. And this really shows that the two interplay well. So even people with erosive esophagitis, there can be some esophageal hypersensitivity there, to where even the esophagitis heals and endoscopically looks great, but they still have these complaints. And certainly as you move further along the spectrum of healing the esophagitis, having less and less visible evidence of disease, you're more and more likely to encounter patients with hypersensitivity who ultimately may fall all the way over into that category of functional heartburn, which are not the patients that you want to be leaning towards surgery on. So I said we would copy Peter Krillis' work a lot. I love this graph, there's several takeaways here. This was looking at all of the published randomized control data on GERD for PPI efficacy. And we can take away so many different notions just from this image. So first, I'd start at the top and show that PPIs heal esophagitis well. So we see the green part of the arrow is the therapeutic gain over placebo. So these are all going to be trials where they compared taking a PPI to taking a placebo, a pill that doesn't do anything. And so healing esophagitis is a sweet spot for PPI. It has a big time therapeutic gain. Another thing to look at is about halfway down there, you see relief of chest pain. And you see that positive pH chest pain and negative pH chest pain are two very different animals. So people who've had a positive Bravo study who have chest pain as their main symptom are going to have fantastic relief of that, most likely with PPI, whereas those who have negative a Bravo study with chest pain, all bets are off, and it's unknown where they're going to land. Another thing to look at is the trend of efficacy. Basically, look at the slope of these arrows from right to left, and you see kind of a diminishing benefit, and that tells you a lot about what you can expect for PPIs. So healing esophagitis, great. Heartburn relief, pretty good. Regurgitation, okay. We talked about chest pain. And then lastly, as you get down to the bottom, you see those atypical symptoms, chronic cough, hoarseness. You're going to get a little bit of a mixed bag down there, but certainly not big time benefit. But these are also less common symptoms, as you can see, and so not as well studied or as well understood. So really just a great overview of what you can expect from your PPIs. And making note, of course, that regurgitation, heartburn, chest pain, none of these are going away completely with that healed esophagitis. So what do we make of those symptoms? So here's a study with 120 patients that recorded over 3,000 reflux episodes. And these are patients who had persistent symptoms on acid suppressive therapy. So these are your refractory GERD patients. So importantly, and for those of you who are looking at this, who don't necessarily get into the stats and the science all that often, but the vertical dotted line is at 1. And what we want to see is the bracketed number, the odds ratio range being entirely above 1 would indicate significance. And so with acidity, we see that acidity straddles that dotted line, meaning that it is not a significant indicator of symptoms in this patient group. Interestingly, though, these two are. So esophageal extent, so meaning how high they refluxed, was key to those expressing symptoms. And then composition, that means a mix of gas and liquid reflux as opposed to just liquid. And I think this, at least to my mind, this makes sense to the what we see from patients frequently, and that those that have more of a belching component, more of an aeration or aerophagia component, are commonly more likely to complain about these reflux symptoms than those who are maybe just having that little bit of liquid reflux that maybe they find more tolerable. So I think that's interesting. Here's a look at 12 patients who have existing GERD who undergo 2-hour studies with impedance and pH in the right lateral decubitus. So they're laying on their sides. This is basically a nighttime study where they've had a big meal and then a snack, and then they do one study on medication, and then they wait a week. You let it clear their system, and then do a second study with the same protocol. And so what you see here is the closest to us. You see the acidic, weak acidic in total. And then when they go on PPI therapy, you just see the kind of teeter-totter happening is the acidity goes down, the weak acidity goes up, but the total number stays the same. In fact, if anything, it's a little more. Basically showing that we're just passing folks from non-acidic reflux or from acidic reflux to non-acidic reflux, but they're still experiencing symptoms. Oh, and the last part there, regurgitation was reported equally in acid and non-acid reflux, but heartburn and acid taste were more commonly related to acid reflux. That was important point. I guess we'll circle back to that right now. And that's looking at the symptom correlation again. So they tied heartburn and acid taste more commonly to those with acid reflux, but regurgitation was more commonly the symptom during acid suppression. So again, people are well treated, but they're having symptoms. So why are they having symptoms? This, of course, brings us back to the first line or the last part of the way I'm thinking about this, which is that they're having symptoms because anatomy is their problem. And we're not changing their anatomy. We're just changing the chemical mixture of what's refluxing and causing them symptoms. So there are temporary aspects to that anatomical problem, and then those can largely become permanent over time. So this is looking back to some of the early work from Tom DeMeester's lab, which forms a lot of sort of our surgical foundational understanding of the LES, the lower esophageal sphincter. So this is the three structural components of a normal GE junction. All right, so 3.5 centimeters of total length, 2 centimeters of intra-abdominal length. Surgical trainees in the room will hopefully recognize that number because that's part of what they aim for at the time of corrective surgery, and a resting pressure of greater than 14 millimeters of mercury. Now that becomes diseased when we see that 80% of patients with GERD, when they studied this, 80% of the patients with GERD had at least a failure of one of these three components. And so these components individually reach failure when the total length is down below 2 centimeters, the intra-abdominal length is below 1, or the resting pressure is below 6. So these are all the indicators of structural decay that lead to reflux. And then I think this is probably Tom Jr. Presented this at DDW, but this is then correlating that notion of failure of these structural components and sort of a domino effect and how GERD follows it. And you see that linear uptrend. They're looking at pH scores or DeMeester scores. You have a normal subjects, and then you have folks who have something they're calling dynamic LES failure or dynamic failure of the LES, where they don't yet on manometry have any of those three criteria, but they are experiencing GERD. And then you cross the line into where they have structural failure of 1, 2, 3, and you see that linear trend going north, kind of connecting those two notions together. So this is another really awesome paper that we share with all the trainees now that Dr. Videlva showed to me that I had not seen before. This is Blair Job's work, and this is really to Brooks and some of the other gastroenterologists out there. This may be something that everybody's been doing, but this is a new way for me of thinking about how to characterize at the time of endoscopy what we see in the valve. And so there's some important terms there as we're retroflexing the scope and looking back up at the valve. And they talk here about the height of the lip, or the thickness of the lip and the height of the body that you see on that right diagram. And these are part of the valve that's formed around the angle of His. And you kind of see that in the top left image there. And so when they looked at this in a cadaver lab, you've got this yellow arrow is indicating that that valve. That's the angle of His. That's where there's a nice sort of fold of the fundus high and the GE junction coming into it. It creates that lip, that valve structure. And then in the second picture, what they've done is pulled down on the fundus to basically eliminate that angle, flatten out that angle, and you see that it immediately opens up the LES, which is a really good representation of loss of that valve function. And so this is another way of looking at that. You see the arrows are indicating that same position, which has gone from a nice tight angle, and then as a hernia occurs, it's sort of flattening out that angle, and you're losing one of those structural components of the valve, opening it up to reflux. Just thought that was a really neat visual. So this is a study from a surgeon, took 100 patients for hiatal hernia repair laparoscopically, got to look at this window once they had taken down all the attachments of the hiatus, and then measured the cross-sectional area of the hiatus. And so the hiatal surface area had a negative effect on LES pressure when they related those two statistically. And there was a significant positive correlation between the size of the hiatus and the number of refluxes in the supine position. So this is going again to the idea of the hiatal defect leading to a physiologic reflux problem. And then the angle matters also. So this was a study looking at 10 GERD patients, again, a nighttime study where they're going to put them to bed and let them kind of roll around and study them. So when they turned onto their right side, that right lateral decubitus position was associated with a longer percentage of time below that threshold of pH of 4 and slower clearance of the acid out. So again, imagining that valve sort of falling open as the stomach is laid on its right side. So one of the messages to patients who have reflux, other than sleeping upright, is avoiding sleeping on the right side. So how do we do this damage to the LES that leads to some of these structural defects? So I'm going to loosely break it into 3 areas, although these really kind of all interplay, as you'll see, particularly over time. But there's sort of this notion of the acid pocket and the distension with a given meal. There's also kind of time, just time under tension. Saw a patient today and commonly see patients who want to know, why did this happen? How did I get this? And often the answer, what I told her today was, sometimes it's just a long enough time our bodies start to break down. And then obesity has sort of a special role in this problem. So this is another sort of novel idea to me that I talk a lot more to patients now about, and that's the idea that every single meal matters. So we tend to think of don't get overweight, don't become obese, because obese people are going to have reflux. But every single meal we have, whether we're thin or not, pushes that valve and it faces it out. And you see that here as you start with this sort of long, tall, thick valve, and as the stomach fills and distends, you pull the bottom part of that valve open, and you create this pocket where there can be the beginnings of intersphincteric destruction. This is another study that got into kind of the details of that. And again, this is another one where I just want to have like one image and just sort of linger on it for a minute because it's so informative and so interesting. Again, I don't know if you can see the arrow or not, but you've got this 4 centimeter high pressure zone. So you can think of this as all those structural components of the valve, right? This is the diaphragmatic cruise. This is the gastro. This is the ligament to the diaphragm. This is the LES. This is that valve that we looked at the angle of His. So this is the high pressure zone that's going to helpfully contain reflux. And this is when we're fasting here. This is your diaphragm, your respiratory inversion point. And then this is the proximal margin of the gastric fold. So this is presumably your Z line. And then with a meal, postprandially, you see this acid pocket that's detected on a pH probe. And you see a shortening of your high pressure zone, right? That effacement of the valve, it's opening up and exposing the lower part of the sphincter to that acid pocket. And you see it, and this is again in a normal person. You see it coming up close to contact with the esophageal squamous mucosa, and you can imagine what that's going to lead us to. So this is a similar picture of the same notion, but again, this is beginning to get at the cellular damage that's going to be done by that acid pocket. So as we dynamically shorten the LES, opening up that effaced valve, we begin to let the acid in and let it start antagonizing that squamous epithelium, pushing it towards cardiac metaplasia, which is going to be the beginning of leading us towards Barrett's. This is the progenitor of Barrett's esophagus and intersphincteric destruction of the valve. So here's what it looks like histologically. On the left, you've got a normal cut of what would presumably be a normal squamocolumnar junction, and there's no gap between the oxyntic mucosa of the stomach and the squamous mucosa of the esophagus. And what we start to see with an abnormal biopsy here is what Parra is calling the squamo-oxyntic gap. And that's where we start to insert cardiac mucosa in place of the squamous mucosa. And so this is arguably the beginning of Barrett's esophagus and the first sign of cellular damage that can begin to lead towards a malignant course and the beginning of evidence of destruction of the valves. So why this matters? So the mucosal innervation is very different for those two cell types. Squamous epithelium is highly innervated. Cardiac mucosa is much less so. So you wind up with less pain sensitivity over time. So you begin to have less sensitivity to that reflux. And you probably either experienced that personally or heard that from patients telling you that things, sort of started to get better. And then next thing you know, there was cancer, there was a hiatal hernia, there was something, Barrett's. The local neural reflex arc also becomes interrupted. So they begin to lose some of that contractibility of the intersphincteric muscles, leading to sort of a dilating of that distal esophagus and a injury to those cells. So the length of the cardiac mucosa on biopsies is equivalent to the loss or the shortening of the sphincter. So this is a good visual representation of that. If my hands in the little screen aren't enough, you begin to see the opening of what was originally a tight, long sphincter, now allowing kind of little peaks of acid in there, confining injury to the LES, but now it's beginning to shorten the valve. And now when you have that big meal and you've got this shortened valve that's been steadily eroded over time, now that big meal blows it open, and now you start to have really wide open reflux, and your injury rate becomes an exponential curve up. So one of the other aspects other than big meals is, like I said, sometimes it's just time under tension. So this is a really good study from Lee. This is looking at over 1,000 patients, sort of plotting all of the characteristics of their studies of acidity, manometry, and biopsies of the length of their lower esophageal sphincter and plotting them against age. And on multivariable analysis, age was an independent risk factor for each of these. And what you see is your esophageal acid exposure going up with age. You see your abdominal, the length of your intra-abdominal sphincter going down with age, and then your ineffective peristalsis, or the less clear, the poorer clearance of esophageal acid going up with age. And interestingly, or condemningly, and sort of to follow up to the earlier mention about the innervation, is that we see, and this is a little tough to look at, but basically, particularly if you look at the male section, which is the diamonds, you see that their acid exposure, as it's trending up, is not following or is not followed by their symptom to the acid exposure. So acid exposure is climbing sharply, symptoms are flat and maybe even declining a little bit. So less sensitivity to that reflux, setting them up for certainly greater damage. And then how does obesity play into this? So as BMI increases, the LES deteriorates and esophageal acid exposure increases additively. So here we're looking at BMI groups from underweight, normal, overweight to obese, and the percentage of them with a defective LES. And you see that number climbing as we climb in weight. And we've already shown that deteriorating LES has connected to a linear increase in acid exposure as well, or a parallel increase. So this is a study that looked at about 250 patients, a little over half of which were obese. They did manometry and impedance on these patients. So their supine acid exposure was significantly higher in the obese patients over the normal weight patients. So when they were laying down at night, they had more acid exposure, which is where we think a lot of the damaging acid exposure comes from. Hiatal hernia was predictive of total acid exposure, as was LES pressure decrease. However, obesity was not independently predictive of either of those. Obesity was connected to an increased gastric pressure, intragastric pressure, and that contributed towards total acid exposure. So we'll get back to this in just a little bit, but certainly these were things that were more common in obese patients, but whether or not obesity was an independent risk factor for these outcomes was less clear. This will look familiar. It's a different finding, a different study, but a similar schematic, and sort of continuing to hit on the same notion that we have anatomic breakdown for different reasons of this valve. So this is interesting. These are all asymptomatic patients, and they're broken into half of them with a small waist circumference and half of them have a large waist circumference. So this is a super thorough study. They've got MRI quantification of abdominal fat. They've done biopsy specimens across the squamocolumnar junction. They've got high resolution manometry and pH study performed upright and supine before and after a meal. And they're watching a fluoroscopy with little clips where they marked SCJ. So really fascinating, really thorough. And what do they find here? So similar to what we saw before, you've got the shortening in the large waist circumference people. The distal component of the lower esophageal sphincter is shorter across the board. And this is not, again, this is, whereas before we were looking at a transient between meals, if I'm full or I'm not full, these are people who are both are fasted or both are eaten. So this is not a change that's happening specific to a meal. This is a more of a chronic change that we're seeing with someone with a large waist circumference. So shortened distal esophageal sphincter. And on this one, we see a proximal displacement of the squamocolumnar junction and a proximal displacement of the pH inflection point. And you see that pH inflection point is above the squamocolumnar junction. So that again just shows you that you've got ongoing replacement of squamous mucosa with cardiac mucosa, maybe ultimately with intestinal metaplasia or Barrett's esophagus, but it's moving up. And you've got acid still reaching above that. So it's a ladder of progression where one injury to the sphincter is going to open up to cellular damage, it's going to open up to more injury to the sphincter, and so on. So it's an additive problem. So the question though is, like I alluded to earlier, is it simply obesity? Is it just about their weight? So although there was an association between increasing BMI and acid exposure, like I said earlier, BMI was not independently predictive. And this is in a study from 2014. And on top of that, the effect of weight loss on GERD is a bit conflicting. So GERD risk factors like hiatal hernia don't improve with weight loss. So once that anatomy is wrecked, it's wrecked, and that's not going to get better. And then while being overweight may increase the risk of reflux, weight loss might not have a therapeutic effect depending on the amount of structural damage that's already been done. So while weight loss is still a standard recommendation, I think my thinking and our thinking should generally be more about decreasing the meal size so that we stop that constant effacement, that constant damage of the acid pocket, and then try to get a reasonable assessment of what the existing anatomy already is. Maybe you can stop it from getting worse by getting control of their weight, intragastric pressure, and such. But the damage that's done may already be done and need to be repaired. So really sweet graph here, a little heat map, again, sort of talking about what plays the biggest role. And so on the right-hand side, you've got increasing BMI. And on the left-hand side, you've got those three structural components of the LES. So notably, BMI alone is increasing your composite pH score. There is a little bit, but it's not a big wave. It's not until you start to break down the LES components 1, 2, 3 at a time that you really start ramping up into those yellow-red colors. Similarly, someone who has loss of these structural components without an increased BMI also is going to have a decent amount of increased acid exposure, but not nearly as much as when the BMI takes off here in these higher numbers. So the two interplay for sure, and have a little bit of independent impact on the overall pH exposure. So these are sort of the three aspects that I wanted to break it down into that can lead to some structural degradation of the valve, probably lead to GERD in most of these cases. So the question then is, what are the consequences of that? And Lee, again, looking at sort of an over time picture. In this case, though, was showing us the increasing esophageal acid exposure relative to the abdominal length of the LES and the overall LES pressure. The LES pressure was not as convincing, but the abdominal length, as it shortened, as they begin to lose that structural integrity, ratcheting up of the pH exposure. Here's another visual representation of it, one that we're familiar with as we think about the Hill classification. We're looking up and grading that valve. So this is a real life look at what we saw earlier in the Job article, where we're retroflexing up and we're looking at the lip of that valve, and we're seeing the degradation all the way up to a significant hiatal hernia. And below that, Orberg and colleagues sort of plotted that against some of the significant things that we care about. So you've got going up from grade 1 through grade 4 in terms of the LES, you've got a steady increase in erosive esophagitis, steady increase in the prevalence of Barrett's esophagus. Similarly, on the right graph, with the percentage of time of pathologic exposure to acid, you have a stepwise increase going up with degradation of that valve. So whatever the causes are that we've looked at, we can see that as those progress through an anatomic destruction, there's a likewise progression of the acid exposure and the injuries that come with it in the Barrett's esophagus. So this was interesting. This is looking at those folks who have 1 or 2 days of a pH study, and sometimes there's a discrepancy. And so the variability between the 2 days, when they did manometry on these patients who had a variability of discrepancy, who had 1 day of pH study that said high Demeester score, high acid exposure, and another day that was more normal. Question is, what was the discrepancy about? And so they found that those patients, compared to those who had 2 days of abnormal, were likely represented or showed early deterioration of the valve, not as complete a deterioration as those who had 2 days of negative exposure. So again, you see the y-axis gives you the percentage of degradation of the valve based on manometry, and you've got normal 2 days pH study. 1 abnormal day is a significant difference, and then when you go to 2 abnormal days, you've got a bigger jump. So again, just showing that there's a linear progression as anatomy fails, acid barrier fails with it. Really cool study from Pandolfino and Carrillis in Chicago. So they've got this radio-opaque balloon across the LES, and they've got patients who are normal, have a hiatal hernia, normal, have GERD without a hiatal hernia, or we have GERD with a hiatal hernia. And so at a pressure of less than 0, they see the EGJ opening on patients with hiatal hernia, basically indicating that even just a normal swallow would open their LES, exposing them to reflux just during routine swallows walking around. And then at pressures just above 0, there were significant differences in the cross-sectional area for the hiatal hernia and non-hiatal hernia GERD patients compared to normals, and for the hiatal hernia patients compared to the non-hiatal hernia patients. So this is, again, just looking at the notion that it's super easy to open that valve as the anatomy breaks down, and thus increasing your regularity of exposure to harmful refluxate or symptomatic refluxate. I think this is the last one. One more time, just to beat this horse fully to death. So this is looking at non-erosive NERD, non-erosive reflux disease, erosive reflux disease, Barrett's. So thinking of those in a stepwise progression. And we see a stepwise decrease of the LES pressure across each of those pathologies. Similarly, you see an insufficient sphincter in an increasing number of those. So that sphincter breaks down, that anatomy breaks down, you get worsening erosive disease up to Barrett's esophagus. You also, along that line, get a stepwise increase in your Demeester score and your pH probe. So I'm going to wrap it up. So in summary, first, make sure it's GERD to begin with. Kind of touched on this briefly, and I didn't want to make this talk about digging into the weeds medically, how to work all these up, but basically we talked a little bit about hypersensitivity. There's other things that cause GERD-like symptoms, rumination, eosinophilic esophagitis, gastroparesis, and my favorite, of course, achalasia. A lot of achalasia patients being referred in, having been treated for GERD for a long time. So we know they overlap a bit. So make sure they actually have GERD first, whether that's through endoscopy, PPI trial, or a pH study. Then take care of the acid. So the acid is what's going to cause the harmful cellular level problems. Take care of that first. That may mean increasing from a daily to a BID to a twice a day PPI trial. You may consider testing their pH on therapy. Saw a patient today in that capacity that had ongoing symptoms, but on study on PPI. She was studied and did not have increased acid exposure. She did, however, have non-acid or weak acid reflux that were at the core of her symptoms. So once you've taken care of the acid, you've made sure that they've got GERD, now you've got to sort out the symptoms. This is a little bit getting over to us probably at this point. These are some of the things that we're looking to do in the workup if they haven't already been done. Probably going to want to get a Bravo if we don't have one already. Going to look with endoscopy. Might consider endoflip in some of these circumstances of questionable outlet obstructions, and then manometry if we're leaning towards doing some sort of reflux barrier. We want to make sure that they have sufficient motility. And then we want to figure out the anatomic underpinnings. So going back through everything that we've talked about here, looking at the valve, figuring out, particularly if we can pin down a definite anatomic problem, that makes it that much easier to suggest a surgical solution. I do think, as you've seen throughout the talk, that there are times when you maybe don't see it, as you've got some of these, transient problems with a valve opening during big meals. Maybe people are a little more sensitive to that, somewhere in that middle ground of interplay between hypersensitivity and real reflux. But so the anatomy is not always obvious, but I think looking for that with an eye to hunting down those anatomic underpinnings of the disease is where we're going to take our final step before repair. And then finding the right solution. And that's going to be, balance between good symptom control against the side effects of a given procedure. And we have a big toolkit now, from endoscopic fundoplications to links to Nissen and all in between. So we're going to talk about that next time and get into the weeds with some of those fixes that we can offer. So I will stop there again. There's the claim code for those of you who are looking for CME credit, and those are our links on social. And let's see if Brooks has gotten back to take some of your questions. If he hasn't, I can freestyle it. But I know he was trying to drive his way home while listening. Let's see here. I'll do him a solid here. I know he had sent me one or two questions in advance. He can't figure out how to unmute himself. Let's see if I can help him. I don't know if I can. Can't do everything.
There you go. Hey, sorry, I can unmute now.
Very good.
Hey man, that was a really good talk. It's a lot of things. It's a talk I wish I'd heard when I was a GI fellow, because it just gives you a different perspective of why GERD happens, because we're seeing these people with in the clinic sitting across from you with these symptoms, and if you think about it from an anatomic standpoint, it makes it easier to think about how to treat them and when to send them to you. But at the same time, it scared me a little bit too, because there are a lot of people we see every day that are obese and probably been eating big meals for a long time, whose carditis has been creeping for a long time, has crept, and those people, we don't jump to scope every time, but are we missing real pathology with those people, and really should we be just scoping obese people? Is there an obese person who doesn't have a problem? You know what I mean? Is there an obese person whose anatomy is normal?
Yeah. I mean, we know that 90% of patients who show up with esophageal cancer don't have a pre-existing diagnosis of Barrett's. Whether that's because we missed them, or they had some other pathologic course that's unknown to us, is unclear. But certainly we lose a lot of people to surveillance opportunities. The guidelines recommend Caucasian or any male with chronic symptoms or weekly symptoms who has one or two other risk factors, being male, being obese, Caucasian, family history, or smoking, which feels like just about every patient we see, is indicated for a screening endoscopy. So I don't, you've got the society guidelines to back that up. I don't think that would be wrong. And I think no question you're going to find some anatomically defective valves in people. And if they've got symptoms and they either fail a PPI trial or even succeed on a PPI trial, but fall in those high risk categories, I mean, I think it's probably going to be a pretty fruitful exercise to screen those people.
Good. And the other thing I was thinking about is, what should our endpoint be with these patients from a therapy standpoint? When we think about inflammatory bowel disease patients, we think of, there's clinical remission, there's endoscopic remission, and there's histologic remission when we're talking about inflammation from the disease process. But with GERD, and I'm talking about real GERD here. You're having some element of inflammation and esophagitis and eventually Barrett's. So should we be, looking at these people, even though they're clinically well, should we be scoping them and biopsying them and confirming and proving that we're halting, the progression of this disease?
Yeah, I didn't get into the weeds of some of the discussion about trying to sort out, non-erosive disease from erosive disease based on, histology. And there's, some mixed data. If you've got an expert pathologist, can you biopsy someone who looks like they don't have erosive disease and early diagnose something? I mean, that's in the weeds, and then there's probably better technology coming down the road to sort that out. So, I mean, I think for now, like I said, the practical side of me just says, take a look if they merit a look, whether that's alarm symptoms or risk factors. Rule out esophagitis or make sure it's healed. If there's Barrett's, get them on surveillance. And if there's none of that, but they're symptomatic, then start thinking about it as an anatomic disease specifically, or talk to someone who does think that way, and figure out who warrants something more, and we'll talk about it next time. But I mean, there are middle ground and there are aggressive treatments depending on how badly you want to control the symptoms and how much you're willing to tolerate in terms of side effects. Nissen's got a bad rap, but there's plenty of ways to do it where it doesn't have major side effects. But then there's also, all the way down to strata or TIF and things that are endoscopic that are much less severe in terms of side effects that maybe aren't going to give you great reflux barrier, but they're going to buffer out those middle of the road patients who just want a little bit better lifestyle without the risk. So I think there's options for them either way. So, not to, kind of pat myself on the back, but I mean, certainly, as a surgeon, I think we're going to think about it more in those terms. And so we're always happy to talk to folks who have, breakthrough symptoms or something that worries you beyond the visual esophagitis.
Right. Yeah. And I think my last point is, that when you're retroflexing the scope during endoscopy, really paying attention to that view of the GE junction is important. I mean, you can ascertain a lot of things about why the patient's having symptoms if you just get that shot. So it's important to take the time to insufflate and get that view.
Yeah, and it can take a bit. It's usually, what do they say, like 60 seconds or more, minute or two, waiting for it.
Yeah.
Yeah, you gotta wait.
I conducted a chat here to see if anybody else had questions, and I haven't seen any responses so far. So
Very good. Well, I got a little long-winded anyway, so
well, thanks, man. This was really good. I learned something.
All right. Well, thanks for moderating. Look forward to seeing everybody next time.
All right. See ya. Thanks.
All right.